2020, sorry, September 15th, 2020. Dr. Duke Majan here. We're at the Duke Spine Institute Surgery Center of Viera, broadcasting surgery, spine surgery live. We've just finished a lumbar fusion a little while ago and our patient's recovering fine. Next is a thoracic Duke laser disc repair. Duke laser disc repair is the name of the surgery. It basically, in a simple form, is go in and repair a herniated disc that's causing pain and neural symptoms such as spinal cord compression or nerve compression. Now what's unique about the surgery today is we're going to be doing a thoracic Duke laser disc repair. Not a common procedure. All right. So, put that down please. We're not ready for that yet. First things first, it's very, very important that we get the right place. Is this something? Are you comfortable, sir? Yes. Dr. Duke here, we're going to get started. Our patient's awake. We're going to put him to sleep shortly, but I need his help in the beginning to make sure that we do everything really nicely. Now, where's the midline? Luis, did you mark midline?
No, but the midline is, this is above the midline, so it's probably around here.
Yeah. So you went past the midline. Understood. How do I know where the midline is? I feel for the spinous processes. Now we need to identify T78, which is hard to do. And this is the first place that we may have trouble, but we're going to go for it anyway. All right, let's get a fluoro shot. And again. Perfect. Okay, so I can see down at the bottom the first rib, and that has to be T12. Shot. So, right about there, shot. Perfect. That is the pedicle of 12, then 11, then 10, then 9, then 8. And we're doing 7, 8, correct?
Yes, sir.
Oh, you can see quite a bit of twisting of the spine at 7, 8. That's interesting. Are you comfortable? Yeah. All right. So I need you to move the fluoro north about an inch. Go ahead and do that. Let me get a shot first. Shot. Okay, let's go back down just a little bit and shot. All right, so that's still T12, pedicle. Then we got 11, 10, 9. So I'm going to try to move up to 9. Shot. All right, so 12, 11, 10. Shot. Hopefully that's 9. It is. 12, 11, 10, 9. And we're doing 7, 8, you said, correct?
Yes, sir.
So I'll move to one more. Right there. Shot. That should be 8, correct? So then 7, 8 should be just above that. So let's move our fluoro north about an inch. And that take a shot. Yeah. So again, that's 8 there. I'm pretty happy with that. 7, 8 has a big beak. Bone spur, you can see it. Let's try to get the AP with the, see how much rotation there is with the spinous process way off to your side? Let's try to rotate it a little bit better. Try to bring the fluoro to you a little bit. Let's see if that improves it. That's better. Yeah, that's good. Perfect. So that's kind of more like midline right there, okay? And basically I'm at 8, and that big disc that looks like a flying saucer should be 8, 9, right? 8, 9. That would make that 9, 10, 11, 12. So I'm right below the 7, 8. So if I were to move up, shot, that should be the pedicle of 7. And it is. All right. So now we need to get the end plates lined up. You see how we're looking down the disc at 11, 12? See if we can just slow little bit movements. Give me a little movement, and then let's see where we are. You're pulsing, correct? Give me a little orbit. Let's try a little more. No, not orbit. Huh? Yeah, cranial caudal. He's correct. Sean, just a little bit. I don't want to lose my pedicles. That's probably better right there. We're pretty much right over where we need to be. So, marker. It's going to be right about here. I want to be right about here. So let me have some num-num. So we're going to give you some numbing medicine, okay? You're going to feel a little stick and burn. Don't be upset. I apologize. There's nothing I can do. That's just some numbing medicine going in. It's going to burn for a second and then it'll get better. Are you still comfortable? Well, all right. Yeah. Shot. That's a little higher than I want, but let's see. Any discomfort there? Let's go with a lateral view and see where we are. You can actually see the hemangioma there. So, all right. Let's go back to the AP for a minute. And we're going to need to probably drop the table a smidgen, but will that affect our lateral? Yeah, we need to drop the table a smidgen on the lateral. All right. Yeah, just a little bit. A little bit. You okay? Shot. Blood pressure is good. Shot. Shot. It's probably a little more medial than I need to be. Let's go with a lateral shot. Yeah, watch the arms. Shot. Just check the arms. All right, so we're still pretty far away. And we're too far south, really, on the fluoro. But let's go back to an AP. And we're going to need to move your base more north. Just first before you do that, I want to look south real quick. Yeah, but go ahead and take a shot. All right, so once again we see 12. Let me have the coker. Yep. Shot. 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 All right, 12. Shot. 11. Shot. Shot. 10. That's 10. Let's go up with the fluoro and keep it on as you roll north. Let's do sin. Cine. Go. Move north. And stop. You're off, right? All right, so we know that's 10, right? 12, 11, 10, 9, 8, 7. And we're doing 7, 8, correct?
Yes, sir.
All right, so 12, 11, 10. And Let's go ahead and move north again, but just leave the fluoro off. Move north a little bit and take a shot. 10, 9, 8, 7. So I'm definitely at 7, 8 on the AP view. And I'm superficial on the lateral view. Shot. That's pretty good. Are you uncomfortable at all? All right. Shot. Shot. Anything? Give me a lateral. The big beak. And you got the twist of the spinous process. You can see the rotation. Huh? We need the table up about an inch, please. Good. All right, let's get a lateral view. Seven, eight. 7, 8. I need the fluoro up to the ceiling a little bit. Good. And I think I see the tip up there in the top corner. You're probably going to need to move the fluoro north. Move it north. Keep going. Yeah, that's not bad. Now you got to do something with this. Try that. That's better. A little more maybe. Yeah, he's just rotated. That's good. That's good right there. Now I need to see the spine better, so I need you to drop the fluoro. And somehow we've lost this component again. So the ribs are malaligned. Shot. That is better. I think we need to wag a little bit. So let's try wagging. I don't care if you want to bring your side north or my side north. Let's try a little wagging. Take the shot. That's worse. Let's go the other way. Go ahead and release the wag and the orbit, orbit I think it is. Shot. All right, go the other way. Pull it down. Keep going. There. Shot. Shot. How's he doing? No problems. All right.
I had a question.
Yeah.
A viewer is wondering, why is the patient awake for this surgery? Is it actually surgery or just a needle procedure?
Oh, it's surgery. So, Sean, someone's asking, why is the patient awake? They're awake because they're helping me to do their surgery. Awake surgeries are done with people awake for a variety of reasons. One is because they can't tolerate being put to sleep with anesthesia. Another reason is because the surgeon needs their help. And in this case, I need the patient's help. He's giving me valuable feedback that I need. All right. So let's try bringing your side down a little bit. Let's see what that does. And shot. Nope, other way. Here, I bring my side down. Shot. All right, that's good right there. Lock everything there. Now I think actually we could do, see the scoliosis is really the trick. Maybe bring my side down a little more. So go ahead and release. I don't think WAG is as much a problem. Shot? That's looking a little better. Lock it there. All right, I think that's where we need to be. Are you still comfortable? Try not to move. Moving is, we spend a lot of time getting it perfect and then you move and we've got to redo it. So try not to move around, okay? Alrighty. So. Shot. Uh-huh. Let's go back to an AP. What you doing?
I got stuck on the armboard.
You got to figure out how to not stick on the arm board and not move the table. So we need to get the table in a place where it needs to be. Can you do that?
Get the table in place.
We can't be moving the table and the floor. We just should be swinging, and that's it. So how are you going to do that?
I'm going to move my base, which is the tab, and just land it
All right. Yeah, we'll never get the surgery done if we don't get the spine and the fluoro lined up and not moving relative to each other. All right, so we need to see that bottom again. I need you to move south and half an inch. Shot. That looks like, all right, so 12, 11, 10, 9, 8, 7. Okay, go back up to where I'm at. Go north about 2 inches. Okay, right there, shot. Uh-huh. 12, 11, 10, 9, 8, 7. Shot. How you feeling? Lateral. At this point, what I need to feel is the facet joint. And we're getting closer. That's not going to work. You got to get me further north. And I got to be able to see that needle on the lateral view. Is that the best you can do? Are you hitting something? Huh? The arm board? So his arm should be in surrender and it should be far enough north. Should be past 90 degrees at the elbow, past 90 degrees at the shoulder. Shot? Is he? Shot? Shot? Go ahead and release this. Shot? Push your side down. Shot? Push your side down. Shot? Push your side down. Shot. That's worse. Go back the other way. Shot. Keep going the other way, as I said. Shot. Shot. All right. Could it really be that much? Shot. Bring your side down a little bit. Shot. I'm getting closer. Let's see. Push your side down a little more. And shot. It seems to be better. It's really hard to say though. The problem is the spine is rotated. Let's try the other way. Shot. Maybe that actually may be a little bit better. Shot. And then a little bit of wag. I don't know which side will go north. It seems to be a little more off there, but shot. That's better down the disc. That's good on the wag. I want to keep it there. Yeah, well, I want to figure out this other plane because the ribs don't look good. That could be some of the scoliosis. But the back of the vertebral body looks better. The facets look better. How could it be off that much? That doesn't make sense. Let's try moving your side down again and just see what that does. More. And stop. Shot. Yeah, I think that it definitely brings the ribs back to where they're supposed to be. Can't say the same for the facets though. All right. Seem to be in the right trajectory. Are you okay? There's the facet shot. Uh-huh. All right. Well, that appears to be the 7/8 disc. Shot. Where do you feel that? Yeah. Do you see the facet joint right by the needle? There's two black lines. Do you see it? Huh? See if you can get those better approximated. So it's either my side up or your side up. Whatever is going to bring them so they're superimposed. I can't say that helped. I think that's better. I think that's better. But again, the ribs are out of alignment. It's interesting. All right, but it definitely looks better from the vertebral body standpoint. What is it? Where do you feel that shot? In your back. All right. Shot? Same thing? Well, we're very close. I don't want you to be too uncomfortable, though. Shot? Shot? Yeah. Shot? It's the same thing. the facet. The trajectory looks good, but it is that facet joint. Let's get an AP view. I feel that we're at the right level. The challenge here is to get past the facet and then into the disc. I think we just need a little bit more lateral. That's what we're going to do. You can go back to a lateral view. Appears we're at the right place. Unfortunately, we're just a little bit too medial, so we're going to work on getting a little more lateral. You're doing fine. You okay? I'm almost done. I just need to get a little bit more to the side. Shot. Shot. Where do you feel that? All right. Sorry about that. Shot. Shot. Same place. Let me all right, we got to see if we can align this up again because he's moved a little bit. So we need to adjust this height. Try one way then the other. Shot. That might be a little bit better. Uh-huh. Okay. Shot. Boy, did it move that much? Shot. Shot. Where do you feel that? In the back? Okay. Good. It's good to know. Okay, let's get an AP view. So for those of you watching this surgery, our patient has a thoracic disc herniation that's symptomatic, and he has failed to improve with non-surgical treatment. So we're left to surgery, and there's only a couple of different surgical options. You can go back to a lateral view. And the kind of surgeries that you'd be looking at that would be successful here would be a thoracic fusion, which screws and rods, or a, and there's different ways to do that, but they're all very invasive. So our patient did not want to do that. He wanted to try the endoscopic way first. If it didn't work, we would try the fusion. So we're giving it our best effort here. We're taking our time. Again, you see how the facets are not lined up? We need to get those facets better lined up, right at the tip of the needle. That's better. Yeah, I think that's better. So we're pretty close, but you know, you can be pretty close in spine and be a mile away. So, shot. 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 Again, we're up against the facet, and really getting around the facet is our primary objective here. I haven't been able to do that. There's only so much I can do safely. Shot. Shot. You still doing all right? Shot. And again, we're lined up nicely with the disc that we want to fix. It's just having difficulty getting around the posterior elements. They're blocking my access. Shot. Shot. I have to be able to get around them if I want to do the surgery. So I keep adjusting my trajectory a little bit. Shot. And retrying, and our patient's been really good. Shot. 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 Again, I keep hitting that facet joint. Bit uncomfortable? Right there. Part of the problem is your facet joints are a little bit enlarged. Let's get an AP. From your injury at this level, as I'm looking here and studying it a little more, your spine is twisted right there at that spot. Huh? Your spine is twisted. You can see your spinous process above this disc and below the disc are in opposite directions. So you had a pretty substantial injury to your thoracic spine. Are you hearing me? And, huh? You don't have to say anything smart. I'm just letting you know. I mean, the trajectory looks great on AP, just lateral, and I'm just hitting that facet. Let's go back to a lateral view. We're at the right disc. I feel confident we're at the right disc level. You can see it right near the tip, but even though the tip looks close, we're really not as close as you would think. We're still in the back. We're too far back with the tip. We're not quite at the disc. So we're still a bit away. Question is, can I get there safely? And I think I can give it a few more attempts. Shot. 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 That might be it. Shot. Might finally be past that. Shot. Yeah, we've finally gotten past the facet. Things are looking better for you, my friend. Are you still comfortable? Shot. Well, at this point, we're in the foramen, and shot. Before I go any further, I want to make sure one more time we're at the right disc. You comfortable? You're doing great, by the way. But just for those of you watching and you understand anything about anatomy, look at those ribs. They're so offset. Why is that? Scoliosis. That's what causes ribs to be further back than the other side. So on one side his ribs are being pushed back, the other side they're being pushed forward. And that's why there's a gap there. Did you know that, Hazel? Of course you did. Hazel knows a lot. She works in my clinic. All right, let's go with our AP view again and see where we are. We've snuck past the facet joint at T78 on the left side. Really, we just got to close the distance here, but I want to, oh, it looks perfect. My God. It looks perfect. Now, well, we need to verify. So let's come down a little bit south and just remember where you were before. Take a shot. All right, so I presume that's 12, and I'll verify that. 12, 11, 10, 9, 8, 7. We are at the 7-8 disc. I've confirmed that on AP. Let's just look one more level down. It should be no rib. Go down one just a little bit. It should be L1. There it is, no rib. So that's L1, 12, 11, 10, 9, 8, 7. Let's go back up to where we were and go lateral. We're ready to finish this thing.
We have a question.
You think you're under a lot of pressure? Yes, I'll take the question. By the way, for those of you watching the surgery, you are watching history. There's no surgeon in the world that has ever done thoracic transforaminal disc repair endoscopic surgery. So has anyone done spine surgery with an endoscope? Absolutely. Not the first person. I'm not the first person to go through the cervical spine anterior. I'm not the first person to go to the lumbar spine through the back. Those approaches were taught to me mostly by the Koreans, but nobody in the world is doing thoracic disc herniations endoscopically. Nobody except for me. Now, I talk to my patients about it always. I full disclosure. I tell them, look, I've only done one of these or none of these or 5 of these. And I tell them, you know, you're one of the first. So is it reasonable to try? Yes. Is it safe? Yes, otherwise I wouldn't be doing it, but there's always a risk of complications. So my patients always accept that risk. They understand what we're doing and they accept the risk. What is the question?
So earlier when you were looking at the report, you specified that the spine was twisted.
Yeah.
One of our viewers is wondering, is that twisting from an injury or from scoliosis?
Yeah, great question. So the injury to his disc caused twisting or scoliosis. Anytime the spine twists, it's scoliosis. But that's from an injury, right? You injured your back. Was that a car crash or what was it? I can't remember. It was a car crash, right? Huh? Oh, airplane turbulence. Okay. Airplane turbulence. So it must have been really bad turbulence, but that's how he injured his spine. And now it's twisting. All right, I just want to see if we can't get that a little bit better. I want to get as close to perfect as we can get it. So we got to do something with that right there. So let's take another shot. Hard to say. It looks better. It looks better to me. I think it's better. So let's just leave it there. Yes?
We have another question. One of our viewers is wondering, why is the thoracic spine so hard to reach transforaminally?
Great question. Why is the thoracic spine so difficult to do? Well, a lot of reasons. One, you got the lung like right here, literally just deep in there. So you don't want to hit the lung. Otherwise, the lung drops. You get a pneumothorax. That's not good. It's not the end of the world, but you got to go to the hospital, have a chest tube put in. It's bad. We don't want that. Second of all, you have the spinal cord, okay? So in the neck, I come in front of the spinal cord, but I never touch the spinal cord. I never go too close to it. In the lower back, there is no spinal cord. But in the thoracic spine, there is a spinal cord and injuring the spinal cord would cause him to be paralyzed. So, of course, there's the aorta, big blood vessel right there. Injure that, and that's really bad. Let's not talk about those things right now. All right, so I'm going to go ahead and get into the disc. Are you comfortable? All right, we're almost done. I just need you awake a little bit. Where do you feel that? Where? In the disc. That's what I thought. Yeah, we're right at the disc right now. Shot. Is that it? All right. Yeah, we're right at your painful disc. So what can you do to help me, if anything? I can't give him any local at this point because we're right on the spinal cord. But I don't want him jumping around. We're gonna make you a little bit comfortable, okay? I just need you awake for just a little bit longer. But everything seems to be going well. Let's get another AP view. Same thing, the disc. Yeah, we're right there. Literally right there. It's like really nice. I know it hurts. That's where you get your pain typically, right? Shot? Yeah, I think we're in now. So let's go lateral again just to verify. And then we've already verified our level, so I'm happy with that. We're T7-8. We're on the left side. That's the side that his symptoms are the worst. Yeah, we're like right there. We're just, sorry about that. You okay? Shot? That's it, we're in. In like Flynn, if there is such a thing. Who was Flynn anyway? Anybody know? Any idea? Why do they say in like Flynn? Which Flynn? Errol Flynn? Huh? Do we have an answer? Are you okay? You're going to hate me, you know, at this point. Yeah. Is that your typical pain? All right. We're going to put you to sleep now. Well, how bad was that on a scale of 1 to 10? What was the worst it ever got? A 10. 10 out of 10 concordant. So, folks, what we just did was, you know, barbaric and torturous, but we didn't do it on purpose. We did it because we need to fill his bad damaged disc with blue dye that stains to or adheres to degenerated nucleus pulposus. That allows me to do the repair that I need to do properly. So the good news is we're into the disc, we're exactly where we need to be. Everything is as good as it could possibly be for this patient. There's been no complications so far. He's just in pain because we're inside that painful disc of his. So for those of you who wonder, do herniated discs cause pain? Absolutely. There's proof. There's no doubt about it. They do cause pain. I want you to count from 1 to 100 out loud for me, okay? Can you do that? Nice and loud. So what I've been able to do is I brought this spinal needle from the skin on the left side through the T7-8 neuroforamen. Okay? I didn't take any of his bone out of his spine. I didn't have to do open back surgery. We're going to do the whole surgery through a 4mm incision. And the entire surgery is going to be done through a little tube right here, guys. See that? That's a 4mm tube. So right where the T8 nerve root is coming out, we're just below it, going into that hole into the disc, just like that. And we're going to do the whole surgery through this incredibly small tube. Isn't that amazing? All FDA approved, 100%. That's my lateral? All right. Shot? I just want to make sure my guide wire is there, which it looks like it is. Just do a little bit more, just to be 100%. Yeah, that looks pretty good. We're there. All right, I'm going to bring my needle out. You saw how uncomfortable it was, Shot? That's because we're in the painful disc. Okay, we know that for sure. We're in the painful disc. Shot? Yeah. I'm going to be in just a moment, okay, doctor? I'm going to be in just a moment, and then you can start letting him wake up just a little bit if you want to, just to keep him safe. All right, so somebody said, isn't this just a needle procedure? If it was a needle procedure, we'd be done. But no, we took the needle out. Now we're going to start the real surgery. You see this knife? That's not a needle procedure, that's a knife. The only people that can wield knives are surgeons, okay? At least legally. So there's our 4mm cut. And now we're going to start the actual surgery. Sorry, yeah. I'm going to bring this, is he okay? I'm going to bring this dilator down the guide wire. We are beyond a needle procedure, just in case you were wondering. This is real surgery. And I don't recommend you try this at home. Now I know the pathway down is clear. It's safe, because I used the needle to find it, and that was the risky part. But now that we're here at this point, we know that the guide wire guides us through a safe passage, through the hills, through the mountains. Okay, shot. We're going to come right down onto the disc, past the facet joints. Shot. Almost there. Thank you, Luis. Shot. I wonder if we can improve that a little bit. I don't really like how he's moved. We've lost the kind of a lateral view of the disc space. See what I mean? Can we improve that? Has he moved, or is it us moving? I think it's him, right? Try again. All right, I mean, that's somewhat better. See if you can do a little better. Keep working on it. I think we're very close to where we need to be. Shot? Yeah, we're right at the back of the disc. Is he okay? Doctor? Let's try to get our fluoro back up north, if you can, just a little bit, or maybe you're already up there as far as you can get. But I want to see if I can. It looks like we're right at the back of the disc right there. Yeah, we're right at the back of the disc. Let's get a quick AP, and then I'll be ready to advance this. Tell me when you're going to take a shot. Shot when you're ready. Good. It's perfect. Lateral. Absolutely as perfect as it can get. All right. Schnoozing away. Is he okay? No, let me do it without. I need a lateral shot. So I need to aim down a little bit. Shot, I think we're in. Yeah, we're in. Take that. Take that. Let me have the mallet. Shot. Yeah, we're in. Now, am I the first person that's done endoscopic surgery on the thoracic spine? No. There is another way to do it, and it's through the chest cavity. And I know that Dr. Curtis Dickman was one of the first to do it out in Phoenix at the Barrow. That was years ago. He developed a transthoracic discectomy. But that's also a major surgery, and it requires being in the hospital. What you're watching today is outpatient. Shot. Almost there. Yeah. And I don't mind if he's a little more awake, if you want to bring him up a little bit. Shot. 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 I think we're inside, and we're in pretty good. Take that. Yeah. This will be a challenge. Thank you for the little miracles. All right. So close, huh? Nice and gentle. You're sure the fiber hasn't, nothing's happened with the fiber, right? It's not broken or anything? Yeah. Because that will be bad. All right. Get that fluoro out, please. I don't know what you're doing with it right there.
We have a question.
Why is the irrigation not on? No. It's not on. Okay? Now it's on. Yeah. Yeah. Sorry, Sean, go ahead.
One reviewer says, I've been diagnosed with degenerative disc disease at C3, C4.
By the way, that's the disc right there. C3, C4, degenerative disc disease.
Yes,
You guys
and
need
they
that light
feel
on your table right there so you can see.
they feel shoulder and neck pain, mostly when they sleep and when they get up in the morning. They're wondering what they should
Come
do
on,
for
man.
treatment.
So you have a herniated disc, you have shoulder and neck pain. Okay. Luis, help them out. And they want to know what to do for treatment. First of all, if you're not having any numbness, tingling in your hands, no weakness, watch your head, no weakness in your arms, then you don't really need to have anything surgical done. But if you're losing balance or losing control of your bowel or bladder, you may want to consider surgery. If you're getting weak in your arms, numbness in your arms, you want to consider surgery. But aside from those symptoms, if it's just pain in the neck going in the shoulders, I would start with physiotherapy. You want to talk to a physical therapist. You want to, what's wrong? You okay? You can wake him up. All right? You need some help? Is our gurney ready? So this goes back to what we were talking about before, the fine balance on anesthesia's part with a prone sedated case. So we don't want to make the patient too asleep. We don't want them to be too awake. You let me know what we need to do. If you need me to stop, I'll stop. We're inside the herniation, by the way, for those of you wondering what we're doing. And some of this stuff is calcified. I apologize for the quality of the picture, but that's really the best we can do with these cervical scopes. Well, there's a piece of herniation. Hopefully we can get it loose and get it out. Let me have the grabber. How are we doing? Yep. I can't see it. Oh. Take a deep breath. We need you a little more awake. Can you do that? Good. Keep breathing and talking to us. You're doing great. Just let us know if it gets too uncomfortable for you. So our patient is talking to us. You're doing great. Everything's going good. We just wanted you a little more awake. Okay? Sorry about that. Almost done. Just probably another 5 or 10 minutes, we'll be done. All right, buddy? Everything's okay. You let us know if it's really uncomfortable, we'll take care of it, all right? See the piece of herniation right there? You're doing great. Everything's all right. You're just getting a little too sleepy for us. Just lay still and everything will be done in a few minutes. I wish I could show you what I'm seeing. You'll probably watch it later when you're a little more awake. But good news is we found your painful disc. What's the problem? Everything good? All right, thank you. What is that? You're doing great. I think that's a piece of herniation right there. See it? That thing right there, that white thing? I'm blasting it. There it goes. By the way, for those of you wondering, herniations never come out in one big piece, though you'd think they should, but they're always in multiple fragments, usually scarred down. You okay, buddy? Yeah. All right, everything's going good. Look at that piece of herniation right there. Uh-huh. What's wrong? All right, what can we do to make you more comfortable? All right. You were telling us that there's a piece of herniation. You were telling us about your accident. You were in a plane, right? Why do I think you're in law enforcement? You are in law enforcement. All right, I won't say anything more. I personally love cops. I know there's a lot of stupid people out there in the world that don't appreciate cops, but I'm not one of them. Yeah, a bunch of herniated fragments. All right. By the way, if you don't like cops, don't bother coming to Duke Spine. Okay? I'm not going to fix your back. Just so you know. Period. End of story. There's no debate. I don't understand why people think it's okay not to obey an officer's orders. I mean, my parents and my school taught me that when I was a little kid. Are people not getting taught that anymore? You okay? Oh. You feel that on your back? Pretty cool, huh? That's that bad disc getting like I'm beating the crap out of it, like you would beat a villain. I'm just kidding. Like we all want to beat villains. Let's not hide our true feelings. You know, I remember growing up watching Star Wars and thinking, it's a no-brainer, right? We want to be good. But I guess there are people that want to be bad. Look at his glasses. Come over here. Turn around, and let her take them off. You don't need those stupid things. Better? You can actually see, right? I'm a little bit, but that's fine. I actually can't see without my glasses. I need, mine? I've got a -6, I think, -6 something. Anyway, this is the herniation, by the way, folks, the blue thing. And we're using this laser, and I know it looks like a big field of view, but this is only about 3.5 millimeters space from one side of the tube to the other. So it's incredibly small. And the blue thing is the actual, where the tear is and the herniation is. So, you know, it doesn't matter if you're doing a thoracic herniation, a cervical herniation, or a lumbar herniation. The anatomy of the herniation is the same. It's an annular tear with the nuclear material kind of coming out through the tear, and that's where the pain comes from, is that tear. Huh? I'm taking it out right now. You feel it, huh? How much of your disc am I taking out? None. I'm just cleaning up the herniation. I'm leaving your normal part of your disc in there. Oh, how much is the herniation? 10% max, maybe 5 to 10%. I can't tell you an exact percent, it's impossible to know, but it's around 5%. We looked at that in our original paper that I published. It was about 5%. That was for cervical though. I think it's about the same, proportionally. I couldn't hear his question. I don't see much scar tissue. I mean, there is a little bit, but not much. You get to watch this surgery later. You're gonna, you know what's gonna be trippy is you're gonna watch your conversation with me right now and go, oh my God, I don't remember having that conversation. That's so cool, huh? You don't want to wait? You want to wait to watch it? Oh, I know you're awake. You're awake, but you're not going to remember this conversation. I have a feeling you're not going to remember. I could be wrong. But every patient I've talked to after the surgery says they don't remember. So I have a feeling that our anesthesiologist has a special, what do you call it, end cap for you? Huh? A little special cocktail right for the end? Yeah, I know. We're getting to that more painful part of your herniation right now. Isn't it amazing that we actually got here? I'm amazed. I was a little worried there. Oh. I almost decided not to do it. All right, so we're disconnected. Standby laser. We're almost done. I need about 5 more minutes. What the heck? Huh? They always say that, right? This is a Duke Spine 5 minutes. I get to define my own 5 minutes because I'm the founder. So it's not a New York minute, it's a Duke Spine 5 minutes. All right. That's what happens when you get a little bit of venous bleeding. I know it's uncomfortable. We're just about done. I promise you. I do it my focus. There we go. I got 2 minutes max. Just the last few touches here. We've already got the epidural space. You can see the bleeding. Bleeding comes from epidural veins. It's very minimal. It's a little bit of venous bleeding. A little bit of fat right there. Epidural fat. I hope this works for you. "12 o'clock is medial. There's a little vein there. We're pretty much done. You guys ready?
Yeah, ready.
30 seconds. Done. Pretty cool. Stand by. Scope, laser. Hold on. Pretty crazy, huh? Hope you all enjoyed that. It was good for me. I think he's gonna be happy with it. I really do. A little pressure just to make sure we get any venous bleeding. I'll show you guys the incision, the surgical incision, in just a second. I just want to apply some pressure. So we treated a herniated disc at T7-8. The left side was worse, so we came on the left side. The herniation seemed to be a little bit worse on the left side. And I offered the patient a more traditional surgery, a fusion, versus trying to do this Duke laser disc repair, endoscopic, transforaminal, full endoscopic with a tubular dilator, minimal invasive, repairing his herniation, and he chose the endoscopic surgery. We went into the surgery. I told him there's about a 75% chance I can get it done. There's a 25% chance I won't be able to do it. Well, we did get it done. And now that we're done, let's see how much pain relief he gets. Just so you know, he injured this disc in a, I guess he's was in a plane, and I think the airplane was violently lurched up and down, some turbulence from the wind. And he injured his thoracic spine. He had pain in the thoracic spine right here where we are. When we went in there today and I did my discogram, I confirmed that that was the source of his pain. We did a provocative discogram. He said it was 10 out of 10 pain, and that's typically where he gets his pain. Now I can tell you folks, for treating this spine pain for 22 years, going on 23 years now, this stuff hurts. And if you've got pain in your spine from a herniated disc, it really keeps you from doing the things in life you need to do, your regular job, your activities, your hobbies, everything. It affects your whole 360 degrees, every part of your life. And he and I have been talking about doing this surgery for months. He really wanted me to do it. I didn't feel comfortable at first, but now after I've gotten now 5 of them under my belt, he's number 6, I believe. 6 thoracic Duke laser disc repair. I felt comfortable enough that I kind of felt like, all right, at least I've done it 5 times already successfully. I can try a 6th time, and I can know when to pull out if I need to. And we got it done. So just so you understand what we're looking at here, can you see this, Sean?
Yes, we can.
Yeah? Sean, are you still there?
Yes. Can you hear me?
Yoo-hoo!
Testing. Can you hear me?
Yeah, I hear you now. Can you hear
Okay.
me?
Yes, we can
All
see
right.
it.
Okay, so kind of his shoulder blade is right here. This is the kind of the low back down here. His neck is up here. This is the middle back. So right where his shoulder blade is, just on the inside, that's where the pain was. Kind of dead center. And it was definitely the disc. But you can actually see the incision. 4 millimeters. Tiny. It's going to look like a pimple once it's all healed. Just like a little, tiny little thing. So I'll take questions from the audience. But you've just watched history. This is the first T7, T8 thoracic disc herniation treated through a transforaminal endoscopic approach in the world. Literally in the world. There's nobody else in the world that's ever done it. And we did it here at Duke Spine Institute. So, hope you enjoyed the surgery. Ask your questions. I'll be happy to answer them for you. They don't have to be related to this surgery. It can be related to the spine. Don't ask me any political questions. Just ask me things related to medicine or spine care. I'll be there in 3 minutes to answer your questions.
All right, everyone, thank you for joining us for the last post-op Q&A of the day. We just wrapped up a surgery. It was a Duke laser disc repair in the thoracic spine at T78. It was a pretty tough procedure, the first one Dr. Duke has ever done, so we were all kind of hoping we could get it done, and it looks like we did. We have a question currently waiting for Dr. Duke's answer. The question is, can a massage machine help with back pain on a long-term basis?
Okay, well, Dr. Duke Majin here. Thanks, Sean. I appreciate it. And wrapping up our 2 surgeries for today and our broadcast. I got a message from somebody that the broadcast wasn't working. The video wasn't working. Is that true? I don't know. Well, hopefully it's okay. Let me start by just saying I just came out of the recovery room, and our patient, we just did surgery, the Duke laser disc repair thoracic. He is a police officer, officer of the law. I don't know if police officer is accurate, but he's an officer of the law, let's just say. And he injured his thoracic at work. He had a herniated disc. We just repaired it. And he said that you can tell the pain is completely gone already. Amazing, amazing, amazing. Pain is gone. So very happy about that. I also checked on our fusion from this morning, and she's going home now. Everything is perfect. She has some discomfort from the surgery, but she's been up walking and peeing, and we're discharging her. So she'll be back tomorrow. We'll get her drain out in clinic, and she's going to have several weeks of recovery. I think she's going back to work in February, she told me. So, fusion surgery recovery is a lot longer. With the laser surgery, like I said, our patient just told me his pain's gone already, literally 5 minutes after coming out of the operating room. So it's great news. So the question was, can massage help with back pain? The answer is yes and no. What the massage will help with is muscle pain. The problem is that muscles are almost never the cause of pain. Muscles are never the cause of primary pain. So what do I mean by that? Okay, well, what I mean by that is the joints of the spine are the actual cause of the primary pain. The pain that is the original pain. The muscle spasms that happen because of pain from the joint. And it's a reflex. Your muscles tighten up and contract in response to joint pain. And the reason they do that is your body is basically trying to do everything it can subconsciously on a reflex basis to protect the joint that's hurting and not move it. So the muscles tighten up and spasm, and that's why you get muscle spasms. So for people who have heard anything about back pain, neck pain, and muscle spasms, the muscles are never the primary cause. The muscles by themselves never cause pain. It's the joints underneath the muscles that flare up with pain and cause the muscles to tighten up, and it's the tightening we call spasms. It's a repetitive tightening, relaxing of the muscles in response to joint pain underneath the muscle that causes the muscle pain. Did I explain that properly? So, will massage ever fix your pain? No. It will never fix your pain. Will massage make the muscles feel better when you have an outburst of back pain or neck pain? Absolutely. I have my own massage chair too at home. I love it. It's my favorite thing in the world. By the way, for those of you who have a massage chair and are into massage, I have an Inata chair, okay? It's supposed to be one of the best. And I'm going to tell you, there's one muscle it doesn't massage. Anybody know what that is? It bugs the heck out of me because I've tried all these different massage chairs that are supposed to be the best in the world, and there's one muscle they don't massage, and it's the hamstring muscle. That's the muscle in the back of your thigh. I just cannot get a good massage chair for the hamstring muscle. They get the sides, they get the quadriceps real good, you get your calves good, they get your gastrocs and everything else, but they even get my butt muscles, but they don't get the hamstring. So whoever's out there making massage chairs, make a massage chair that gets the hamstring and you'll make millions of dollars. Do we have any more questions? All right, so maybe we'll have a treat for you. I'll go see if our patient wants to do a testimonial, and we'll get him up and we'll ask him how he's feeling.